Welcome back. Today we're going to study the physiology of the heart and try to put into effect some of the practical aspects of how this wonderful mechanical pump works. By way of review, remember now that we have this very small, very efficient pump pushing blood, a very viscous liquid, through some 50,000 miles of vessels, both gross and microscopic, and beating at a rate that is able to put out some 20 quarts per minute at rest and much more during exercise, which amounts to about 1.5 million gallons a year, year after year. During an average cycle, let's say with a cardiac rate of 60 beats per minute, the rest period is less than a second. You can increase this factor by factors of 5 or even 8 times as much under conditions of extreme stress, and the heart is up to the job. There's something called cardiac reserve, which is enormous. This is a ratio between the maximum cardiac output and the resting output. And this is the figure that I mentioned, some 5 to 8 times the volume that can be delivered over what's delivered normally. Now, before we get into the actual physiology itself, there needs to be just one more definition before we get started, and that's the difference between systole and diastole. And it's important to understand when we talk about those two words, we're talking about the ventricles. When the heart squeezes to make its pumping motion and pump blood out, during the active time of squeezing, the high pressure propelling of blood out the major vessels, whether it's the pulmonary or the aortic vessel, the active squeezing is called systole. That's the high pressure end. Diastole is the relaxation that occurs during filling again. Now, of course, the atria both have their own systole and diastole, which are at a different timing than the ventricles, but unless we say it specifically, when we refer to systole and diastole, we're only talking about the ventricle, ventricular systole and diastole. So let's talk a little bit about the physiology again and go back to reviewing this slide of the heart. We have our right and left sides of the heart and the atrium, which is very appropriately named as the waiting room. Blood flows in to the atrium and then flows in by being pumped into the ventricle. But the atrium is not necessarily very efficient or powerful. And if we lose atrial contraction, which we can do in disease states, the efficiency of the heart is only dropped somewhere up to about 30%. So, for example, there is a disease called atrial fibrillation. Fibrillation means uncoordinated contractions of the muscle. Instead of the atrium giving a good, solid, coordinated pump, it may wiggle like a bag of worms and really not pump anything. There's something called ventricular fibrillation, which is not compatible with life. That's what we often call a cardiac arrest, and that's what's happening when you see them put the paddles on somebody and shock them. They're trying to convert that fibrillation, the worm-like motion, back into a real contraction. In atrial fibrillation, patients can live for years with it. No effective blood is being pumped. It's merely being passively drained into the ventricle, either by gravity and or some suction that's created as the ventricle expands. So this part of the cycle, whether it's the right or the left atrium, means that we get extra efficiency by having good contractions, but not necessarily important to life or survival. We're going to talk about that more in just a minute. I want to move on to the conduction system, because in the conduction system, we have a lot of places where absolutely critical pinpoint timing is involved. As I told you, about 1% of the mass of the heart is designated as an autorhythmic, self-exciting type of fiber, one that inherently will make itself discharge electrically, and those electrical discharges will make the heart contract. And what happens is it starts up here in the sinoatrial node and propagates, meaning every millimeter along the way discharges the next millimeter, so the electrical wave passes along in a coordinated way down the atrium and into ending up here at the atrioventricular node. This node then picks up the beat and moves it on through the atrioventricular bundle of His. His was a man who discovered this physiology and got his name stuck onto it. You're going to hear a lot of those eponyms during this course. And then everything divides pretty systematically and moves along the rest of the cardiac muscle to make it contract. Now, again, evolution has done an extraordinary thing. It's made a little roadblock here. Remember what's happening. If you look at the atrial contraction, the electricity has come down very fast, but it takes a few microseconds for the muscle to respond. The ventricles would really like to have all the blood in there that it can get before pumping out, and I'll explain why. And so it takes a little extra time for the response to make these atria contract and then to get the blood into the two ventricles. This roadblock right here at the AV bundle is the one that does it. It slows conduction just long enough so that the electricity is held up, just like a traffic jam on a highway, and these atria have the ability to empty themselves completely into the ventricles. The ventricles then go ahead, fill, and do their ventricular ejection. There are disease states in which these fibers get blocked. These are called bundle branch blocks. You have a right and left bundle here because they're bundle of nervous tissue, or myofibers of Purkinje is what they're actually called, another physiologist who attached his name. And something that happens to the myocardium, for example, a heart attack, instead of striking the muscle out here, it might strike the muscle right here and not only injure muscle, but might injure the conduction fibers. And that patient would have what's called a bundle branch block. If the block is severe enough and the pacemaker is not getting down to the portions of the ventricle that they need to, what's going to happen is the ventricle will then pick up its own autorhythmic rate. Remember I said that the ventricle's rate is very slow. Took that ventricle out and put it on the table, it would pump around 20 or 30 beats a minute very slowly. Only reason it's going 60, 70, 80 beats a minute is that it's being whipped by the node. The atria, their inherent rhythmic rate is whipping the ventricles. So what happens to that patient? Well, the first thing that happens is the patient may faint. Patient who has complete heart block or partial heart block may slow the rate so far down that the brain isn't getting enough blood or oxygen. Patient might have episodes of fainting, might have episodes of just feeling faint or weak or short of breath, and would go to see the doctor, who would see that their heart rate is actually only about 20, 30, 40 beats per minute, not enough to do the job. And we have now a rather simple cure for that called a pacemaker. Patients then have a wire placed in their heart attached to an electrical stimulator, and what happens is that is fed through usually either a vein in the arm or a vein in the leg. It's fed backwards up into the right atrium through the vena cava, which is this big vessel, and down through here under fluoroscopy and wedged against the heart muscle. The pacemaker then sends little impulses at whatever rate we want and determine, and it does the same thing the node does. But now we're bypassing this block and pacing the heart down here. Now, when I first went into medical school, these pacemakers had a fixed rate, so we made them go about 70 or 80 beats per minute, which was adequate for most people, but they could not increase their rate if they had to. The battery life was also not very long, so these pacemakers had to be changed. Today we have demand pacemakers, which have computers in them that can sense the need for increased rate